As I was walking out my room this morning, my wife says, "Aren't you giving a talk? Aren't you going to wear a tie?" I said, "No, from now on I'm going to sport the Andrew Yang look." So $1,000 to everybody after the talk. You have to be a Democrat to know who Andrew Yang is. Okay, so a few months, probably 6-9 months ago, Christian asked me to see if I could come and give a talk on what we've been working on, and obviously you don't say no to Christian. But what I wanted to talk about really is, as a whole, nasal-maxillary expansion for the treatment of sleep apnea. I think it's important for us to really review what's been done, and obviously I'd like to talk about what we're doing. I have nothing to declare. So we have to really give kudos to Peter Li. He was the first to describe maxillary expansion for the treatment of sleep apnea. But if you take a look at the 1998 paper, it's mostly adults. Okay, Paul Pirelli was along with Christian, was the first to describe maxillary expansion in the pediatric population, and you can see that the mean age was 8.7 years old, with fairly significant improvement in sleep apnea with maxillary expansion using the traditional rapid palatal expansion. And Christian and I published maxillary expansion and mandibular expansion to try to surgically maximize the result, and that was in 2004. Subsequently, Dr. Vella from Rome, and then Christian and Stacy, they published their results with now Stacy, at that time Stacy was doing bimaxillary expansion with rapid palatal expansion in the treatment of pediatric sleep apnea. Obviously, there's a fair number of papers been published. The 2017 paper looked at number of studies, but really it's in the pediatric population. As we age, there's gradual ossification of the mid-palatal sutures, and starts from the posterior and the PNS region and going anteriorly. So the maxilla and the skull becomes more difficult to expand, okay? And if you really critically looking at the data, most of the expansion is the teeth, the alveolus and the teeth. We are using a dental treatment to try to improve the airway. It's an adaptation to try to manipulate the airway. So if you look at it, somewhere, it's some studies showing 4 to 1 dental to skeletal effect. And most of these changes were really in the anterior nasal airway. Remember, the posterior nasal airway is very difficult to expand. Okay, usually if you expand at the molar area about 8-9 millimeter, you maybe only get about a couple of millimeters in the nasal airway opening. Okay. When people get older, the traditional surgical procedure is SARPI. You know, we do it for starting from the late teens. The 2000 paper was the utilization of SARPI to treat sleep apnea, and there you can see that a LaFour cut, horizontal, and a midline cut. So it's not, it can be fairly invasive. And this is a 2004 paper because at that time I was so proud of myself when we were Christian. Was like, look at how much we can expand. Okay, these are 12, 14 millimeter expansions. And I've been doing number of expansions for the past 15 years, but this patient really hit home for me. That she's a very nice woman with mild sleep apnea, but very symptomatic. Okay, she was very fatigued and has significant nasal obstruction. I expanded her using routine traditional technique, and she came to my office, and I said, "How are you doing?" She goes, "I still can't breathe. I feel the same." As I tell myself, it can't be. I'm a surgeon. 100% of my patients improve. That's a joke, okay? And so I got a CT scan. So if you can see on the left, it's, you see the LaFour cut, you see the midline opening, you see the big diastema, but it's a cone-shaped expansion. All the expansions in the front, okay? And I expanded more, hoping that it's going to open her up more. And it's further anterior expansion. There's no posterior expansion. So we have a cone-shaped expansion. And then start really looking at all the literatures, and so basically that is the pattern of maxillary expansion exists today. okay? Whether it's rapid palatal expansion in kids or surgically assisted rapid palatal expansion in adults, okay? And in the process of trying to manipulate the skeleton via dental means, we are over-expanding, creating a very wide jaw and increasing risk to the dentition, to the periodontium. And sometimes there's no improvement at all. This patient came to see me from New York, and obviously he has a pretty significant malocclusion, but the reason for his surgery was to treat his moderate sleep apnea. He had his surgery. You could see that the expander is maximally extended, and he has a diastema, but he has no improvement. He has no improvement because there's no skeletal changes, okay? You see the anterior, there's no change. In the middle of the nasal airway, there's no change. There's no change in the nasal airway following a fairly significant expansion. Recently, the past few years, people are talking about MARPE, using mini screws to try to expand the maxilla, advocating it because of the skeletal effect. There's some literature there. But if you're really critically looking at the literature, it is the same thing. Dental expansion is greater than skeletal expansion with MARPE, okay? And what you find, the measurements, first molar, 5.6, and the nasal airway, and measuring at the anterior nasal airway now is 2 millimeters in the nasal airway expansion, okay? And there's no posterior changes at all, regardless what type of micro screw that you use. Again, it's a cone-shaped expansion. And the study on MARPE with sleep apnea is scanned, and they're all in younger patients. I said that. Patients older than mid-20s have sleep apnea also, okay? And we can't really extrapolate the pediatric data into the adult data. I just want to take a moment and just mention something. In my practice, I'm seeing increasing number of patients that come in to see me with all sorts of different methods of maxillary expansion. This first patient is almost 50 years old. So you can see that her practitioner are extending, widening, or advancing the alveolus, pushing it out of the socket, telling the patient that they're trying to improve her airway, and then retracting the teeth back. Now, moving the teeth, it does not improve the airway. Second patient in her 60s, moving the teeth. The third patient is a 30-year-old guy with severe sleep apnea after an ELF treatment, getting the teeth pushed out. And the last patient is a child who has 6 or 7 years of ELF treatment. And there you can see that at the last couple of images, they're successfully flaring out the teeth out of the alveolus and thinning out the buccal plate, but there's no change in the airway and no improvement in symptoms and no change of sleep apnea. Okay, so not all maxillary expansions are the same, and not that they can improve the airway and sleep apnea. So really, we're trying to use a dental treatment to try to manipulate the nasal airway, the skeleton. Okay, and this is a procedure that's been developed a couple years ago. I just want to mention, Dr. Kuo and I and Chris John have been working together since 1998. And I would just say that obviously they're never satisfied with my work. Never, okay? And I certainly would not be here without them. And I certainly would not be the surgeon producing the results that I'm getting without them. So I just wanted to mention that. So we're trying to develop a skeletal expansion to really expand the nasal airway while minimizing risks and complications. So the procedure is done endoscopically. So whenever you are making a LaFour cut, you are trying to expand this area, okay? And when you're trying to expand this area, you have to overexpand, leading to risks and complications of the maxilla. What we're trying to do is basically extend the apex expansion to the nasofrontal region and creating an opening of the entire nasal floor and really significantly expanding the nasal airway. It's simple geometry. It's easy to show a 22-year-old guy with through and through nasal maxillary expansion. Okay, these are not the difficult patients. It's predictable. Let's look at some more difficult patients, more challenging patients. 40-year-old engineer, fatigue, moderate sleep apnea. He hasn't used CPAP because he couldn't tolerate CPAP. Okay, he was expanded. There you can see, small amount of teeth separation. You can see that in the molar area, not a whole lot of separation. Anybody that look at this is going to say, what did he do? 5 to 6 millimeter nasal floor expansion from ANS to PNS, a significant symptomatic improvement. There you can see the nasal frontal changes, radinasion. Before and after. Okay, 48-year-old on BiPAP. She had a lifelong history of nasal obstruction and sleep apnea. She had nasal surgery twice, ortho twice, struggled with BiPAP. She comes and saying that, I don't care what I look like, I want to be able to breathe and sleep better. I never believe them when they tell me that. Okay. So, and you can see that fair amount of periodontal problem, minimal periodontium support, teeth on a pedestal. She was expanded. Okay, you can see that, we'll push out the expansion because she wanted to maximize her improvement, but, this is skeletal change. 5 to 6 millimeter nasal floor throughout ANS to PNS, and expansion of the posterior in the nasal pharynx at the PNS. Changes at the nasal frontal region on a 48-year-old with significant expansion of the nasal airway. These are before and after. And every patient that I've expanded with, there are a number of reasons that I would expand a patient. One is to try to reduce the CPAP pressure requirement. She was on fairly high pressure, 17 over 12 on BiPAP. In the middle of expansion, toward the middle of expansion, her CPAP pressure dropped 5 centimeters of water. Those of you who want to sort of validate what I'm saying, you can ask Shannon Sullivan. She's managed a number of patients with, and in the very beginning, the first week, barely a millimeter expansion, we're seeing drop of pressure requirement. It's just because, just the geometry with expansion of the airway is tremendous. This is an interesting patient, 50-some-year-old man who actually came to see me 8 or 9 years ago. He has severe sleep apnea, had nasal surgery, still can breathe through his nose, UPPP, repose, hyo advancement, nasal valve reconstruction, etc. So about 8 years ago, I did a MMA. There's before and after. You can see that it's a fresh post-op and the osteotomies are still there. I just want to make a comment on the MMA. You can see that there's some small plates and few screws. I'm seeing increasing number of patients who have an MMA who just has what I call a ton of titanium put in. What I call titanium toxicity, okay? There's no reason to put in all those metal and foreign body in someone. It's just gonna increase the complications. And the reason he came back to see me recently was because he brought his son. I did, as you know, sleep apnea runs in families. I did an MMA on his son, and he came back a while ago. He came back to see me because his son's leaving for college. He wanted him to have one more checkup before he sends him off to college. And he was fine. Again, there's no titanium toxicity. So we talked, and he still said, I feel great, but I'm starting to have a little bit of snoring, and I still can't breathe through my nose. I said, okay, well, I developed this procedure. I think it's reasonable for you to give it a try. So you can see on a 55-year-old, there's a little bit of, there's skeletal expansion, but the teeth move a little bit. I do want to make a comment that sometimes the teeth get pushed out a little bit, But in this type of expansion, there's no buccal plate changes. Okay, you're not pushing the teeth out of the buccal plate, just sort of alveolar molding. And there's expansion. Since the goal of the apex expansion is at the nasofrontal region, there's no reason for me to remove the plates, right? Because I'm not expanding here. I'm expanding the entire nasal airway. There you can see. He flew in Thursday, I did surgery on a Friday in the office, and he went home 3 days later. Okay? 60-year-old, moderate sleep apnea, can't breathe through her nose. And she's not going to have a bimaxillary advancement, and I'm not going to do a UPPP on her. So she was expanded, okay, a couple millimeter of diastema, 5-6 millimeter expansion from the ANS to PNS. And you can see the changes in the nasofrontal region. One last patient, severe sleep apnea. I actually did a bimaxillary advancement of SARPI on her daughter. And she had a problem with CPAP. She was expanded. There you can see on a 63-year-old the pattern of expansion with change of the nasofrontal region. So significant expansion of the nasal airway from the ANS to the nasopharynx. Okay? Some of you know who that is. There's no further validation of the trust of someone who asks you to operate on their relative, and I'm certainly honored for that. So Christian asked me to treat he has significant nasal obstruction. About 15 years ago, I did an RF turbinate reduction in the office, didn't do much. And about 10 years ago, I did nasal surgery, septoplasty turbinate reduction on him. He still can't breathe through his nose very well. Now he's 40 years old, and he's starting to have a little bit of snoring. So that's his CT scan. He flew in on Wednesday. The image was taken on Friday, right after he gave a very nice tribute to Chris John at the wake meeting. And then this picture was on Friday right before surgery, and this picture was taken on Monday before he flew out. Okay. Then you can see that I started expanding him on Monday with a small diastema, and there's expansion. And we're going to continue to expand. You know, practicing in Silicon Valley, the issue is that you have all your patients that are much smarter than you. An engineer came in saying that, he has looked at and studied all the expansion techniques. And he analyzed everything. He says, okay, I'm going to have you do the ease on me. And what he did was he basically took a sort of a typical measurement of the skull, okay? And then the lower left image is a SARPI. We're looking at a 10 millimeter nasal expansion. Nobody does a 10 millimeter nasal expansion on the nasal floor. You get the typical fan-shaped expansion. You get about a 5.5% expansion. The second expansion is anterior expansion only with 4 millimeter, and the last is endoscopic expansion with a 3 millimeter expansion from the ANS to PNS. There you can see the tremendous airway expansion that you can achieve. Computational fluid dynamics showing the airway is significantly, the negative pressure is much improved, less airway obstruction and lower airway. This is a paper published a couple months ago. You see the improvement of the, granted these patients aren't all that severe as Christian will say. The ODI was about 12 to 2. With improvement of HI oxygen saturation. So our protocol currently is bimaxillary expansion by Stacy, and between 9 to 16, 17 late teens, I would just basically place a skeletal expander. No bone scoring, and then beyond that, it's the ease procedure. I see that on my schedule. Stacy's referred me a 70-year-old. We'll see. Okay, just a word on pediatrics since I'm supposed to talk about young patients. two patients. 13-year-old with sleep apnea, daytime fatigue, and sleepiness. She was expanding. You can see that it's, you look at the dentation, it's not that impressive, right? Okay. There's expansion. Okay. There's the nasal frontal changes. It's simple for the younger patients. Okay. And expansion at the area changes at the ANS and the nasal pharynx at the PNS. This is the only way you can manipulate the entire nasal airway. That's her computational fluid dynamic analysis, significant improvement in the negative pressure. There you can see this, Stacy just gave this slide to me. So you can see that we follow our she follows all the patients. There you can see the adaptation of the muscles, and she was much, much improved after her most recent expansion. Just remember the patient that I mentioned with the ELF, with moving the teeth out of the alveolus? She was expanded, and I try to maximize her expansion. Okay. And you can see the tremendous improvement in the negative pressure generated looking at before and after. And this is the most recent pediatric data that's in the process of being submitted. Thank you.